I don't know. Okay, right, that's exactly right.
Thanks, guys. Okay, I guess we were just talking about how you guys are being tested, and I guess PEDS lectures this week, so I'm not sure how much you guys will have of this on your lecture, but just some highlights on our sarcomas, because you guys may get much more of this as you go on. Just knowing kids, it's always distal femur proximal tibia, okay? Been doing orthopedics for over 10 years. I've seen one osteosarcoma, okay, ever. So that's how rare it's a zebra. You just don't see it, but when you do see it, you won't forget it. The individual I saw, I've seen it in, he was actually an adult, and how we found out that he had an osteosarcoma, he was coming in for shoulder surgery, 70-year-old, 40-year smoker, really nice guy, but he had an adhesive capsulitis to the shoulder. He basically talked my doctor into saying, hey, I don't need an MRI, because on x-ray everything looked great. You didn't have this, this sunburst appearance. Again, his sarcoma looks nothing like this. But, we take him in the operating room. The first thing we do for somebody that has an adhesive capsulitis is we manipulate him, okay? So he's stuck, can't move his shoulder at all, so we go to take his arm and go through manipulation, and what do you think we hear? Snap. Broke his arm. So, right then and there we thought, oh crap. So, broke this guy's arm. Why? Well, now we get the MRI, and he did have, unfortunately, lung cancer, which metastasized to his proximal humerus. He lasted about 6 months. Okay? So on x-ray, didn't see a thing. We went back, actually had 4 sets of x-rays on the guy. You did not see anything. So that's how rare this can be. But the thing that I kind of kicked myself about, well, he's a smoker. Well, how many smokers do you see in Oklahoma? Everybody smokes, essentially, if you're over the age of 50. So, again, just know sunburst appearance for a test exam. It's typically from the lung as far as metastasizing, and then, painful swelling in kids especially. So, if you see someone on x-ray, this is another thing I want to talk about. Had a student one time. X-ray looked a little funny, okay? This is, again, it was a student from OU, this was several years ago. But just watch what you say to parents, because there was nothing wrong with this x-ray, had a little dysplasia, but the student used tumor to a parent. The last thing you ever want to do as a student is use the word tumor, because then we got to talk our way out of it. This lady wanted, a $10,000 workup on her child because a student said possible tumor. It was dysplasia, it was nothing, okay? So you can really alarm parents by going in there and saying, well, this looks really funny, or this doesn't look right. Just know that once you get in practice, MRIs are the way to go, especially if you go to do orthopedics. It's going to tell you what you need to know. So just watch your language with them. So again, once you get to this point on osteosarcomas, and this is where Kim Smith comes involved, Dr. White, some of the big orthopedic oncologists, we don't do any limb spraying stuff. I mean, we'll have to go through chemo and radiation. This can be really debilitating for the kids, of course. Ewing sarcoma, again, only time you ever see this is early on exam. The main thing on Ewing sarcoma, I'm just going to skip ahead, is the onion skinning. It will be a test question. It will be on your boards. This X-ray, something very similar to that will be on your boards. That's really the key factors: is onion skinning and pediatric kid, distal femur, or in the humerus. Okay. Or surgical resection, chemo, and radiation therapy. Good X-ray there. Again, sarcoma on the left, and then you have the onion skinning appearance on the right. That looks like an onion. I don't know. So maybe it does, maybe it doesn't. So osteogenesis imperfecta. Again, it's one of those zebras. You never see it for test purposes. Of course, type 1 collagen, that will be on there. And then the blue sclera, that's always on there. That is, the key factor, key words as far as for testing. Okay. And again, I'm just skipping ahead through some of these because I want to really get to the fractures, because this is where I think it's something that's going to be pretty important to you. Let me pull a different PowerPoint up here real quick, if I can. And so if you guys want to go to your computers too, because we're going to be using this website quite a bit, it's called Ortho Bullets. SolterHarris.com. I would save it, put it in your favorites. It is the #1 website that we use when we're looking for anything out of the norm as far as treatment options. It's just a really, really good resource. I mean, there's really 3 websites that I use on a daily basis. It's Fast ICD-10, Hippocrates, and OrthoBullies. Those are really my go-tos, okay? If it's not there, then I don't know. So, or they don't know, okay? All right, so let me go back here. And I'll send this to you guys, but it's only a few slides, and it's just some basic information, because this PowerPoint did not have much on Salter-Harris fractures, which to me, PEDS is, again, probably one of the more important things that you need to know. All right, so Salter-Harris fractures, Dr. Salter, Dr. Harris, I guess, I don't know, some dead guys that got to name all this stuff. So, of course, fractures through the growth plate, unique to pediatric patients, and of course they're graded in 5 degrees, so just 1, 2, 3, 4, and 5. Some types of fractures, of course, are categorized that way, but then pathophysiology, if you really want to know the pathophysiology, you can really get really in depth to that. Just know that, if the epiphysis is disrupted, if there is disruption to the blood supply of that area, you will have growth arrest. And so, some of these fractures, we'll talk about that, which ones you have to really be concerned about. Type 1 is a transverse fracture through the hypertrophic zone of the epiphysis. You do have a little bit of widening that does increase in the area. Of course, this is the growing zone. You have growth disturbance is not is extremely uncommon, sorry. And then, of course, on a physical exam or clinical exam, these are my favorite types of fractures because a kid comes in, they had a fall, you x-ray them, they hurt right over the physis, and then you're a hero because really, is there a broken bone? Yeah, you can categorize that as a broken bone. You can bill it, which we're all in this to also make money too. We want to take care of patients, but this is a fracture code. If they're hurting over the physis and they're point tender over the physis, to me that is a fracture until proven otherwise. Because you're not going to see that typical gapping of the physis on a Salter-Harris 1. So I tell the parents, especially on distal radius, hey, we're going to cast them 2 weeks, they're going to come back, they're going to feel great, and then you're their hero, okay? But again, that is a fracture code, okay? You'll learn more about billing later. I wish that's something that we would touch more on in PA school is billing, because it is so, so important, especially with the new ICD-10 now. So, type 2, fracture of the physis and to the metaphysis. Typically, the epiphysis is not involved. Getting into the cartilage may cause minimal shortening, pretty rare, but this is the most common Salter-Harris fracture you will see. Had one last week on a kid that had a distal radial ankle sprain. He had one in his distal fibula. Radiologist missed it. So don't always believe the radiologist either, okay? So on his lateral view, you could see it going right up, and it was actually his original x-ray. So, because the radiologist called it no acute fractures, well, abnormality, open growth plates. That was it. But the kid did have open growth plate fracture. So, and we'll get more to what a picture of that looks like in just a second, okay? Type 3, fracture through the, of course, the physis, the epiphysis, and then this does involve the cartilage layer. This can be debilitating, okay? Because once now you get a fracture that gets into the joint, and if you don't get perfect alignment of that cartilage up, they're going to get arthritis. And for a 10-year-old, that's going to affect them 20, 30 years down the road. That can be awful, okay? So, of course, on a type 3, this typically turns into, unfortunately, surgery for that young kiddo, okay? 4, now you basically have gone through all 3, okay? So you have the epiphysis and the metaphysis and the physis all involved. Again, deformity to the joint is usually involved. There's usually a lot of deformity just to the joint in itself. A lot of times I think of these as ankle dislocations. Those kiddos usually have all this together and combined, and you a lot of times will get growth arrest with this also, if you don't get perfect alignment on that patient. Type 5, never seen it. Okay. You know, it's basically from a crush type of injury. You basically have disrupted the physis itself. Blood supply has died off, but again, I have never seen this. It may be one of those things that they've already gotten to the pediatric orthopedics before it gets to us. Okay, so if I was worried about anything, especially in your pediatric rotations, one things I would be worried about was really more is just type 2. Okay. And type 2s, again, those are the types of fractures you're going to be heroes on, because as long as there's not much displacement, you'll cast them up, and then they'll come back in a few weeks and they'll be nice and healed, because kids are like salamanders. They heal extremely quickly. Okay. All right. Let's see here. Now, if we go to Ortho Bullets, a little website. All right, so if you guys go to topics, okay, I'm kind of hovering over topics there. If you drop down to pediatrics, all right, this little bar off to the side has about everything you ever want to know about pediatric issues as far as dealing with bone, okay? Stuff that is much more involved than you'll ever want to see. But if you go up to very top, physical consideration, some good stuff here. So there's a great picture of just the different degrees. And so just like on, type 1, of course we're just worried about this widening here, but the type 2, you can see it goes above the joint. So have you guys seen the little acronym SALTER? Have you guys all already seen that? Okay, so you know what I'm talking about. So because I don't know why some people have a hard time remembering which is which on these, but this and this, when you have joint involvement, you're going to get some arthritis that occurs in this area if you don't get that cartilage lined up perfectly. Okay? So this is where if you're working in peds, if you're working in the ER in Frederick, Oklahoma, if you see this type of fracture and you're calling up to McBride and you're saying, hey, I have this 8-year-old female, describe that to us. If you see there is a joint involvement, we need to see them pretty quickly. Okay? Because, again, this isn't something that needs to be put up for 2 weeks, and unfortunately with Sooner Care, for instance, have to go through their PC, it will take them literally 1 to 2 weeks to get over to see us. By that time, it's too late. So this is something I would highly recommend if you have a kid like this, stay on top of them. I mean, this is something you have to call about day in, day out. And again, it's not your fault, it's not your problem, it's the insurance problem. But they will not get the kids over to us quick enough sometimes because of that. And you can affect the kid for the rest of their life if you don't get them to us. Okay? All right, understood? Questions? No? Okay. If you want to know about the growth areas, there's the growth areas. Simple long bone fracture, forearm fracture. Is that forearm? I think it's forearm. I can't tell. No, that is a tib. I don't know what that is. Again, here is just talking about the different vessels. Testing purposes for McNeil, maybe. You may want to know this stuff, but for your PEDS lecture, I bet not. Okay. Let's go to. Let's slide on down to just the radiuses. Okay. Because this is what you will commonly see. Okay. What do you think we have there? Is it a 1? Is it a 2? Is it a 3? Is it none? I'm gonna say it's none, okay? Have a little buckle fracture here, doesn't look like the growth plate's involved. So a little bit of a trick question, sorry, okay? One, two, or three? Three? Did I hear three? I'd probably say one, more on the ulna. There is some widening of the ulna there, okay? Looks like it's well aligned. Maybe a little bit slipped here off the distal radius, and we're not aligned here so much, okay? What do you think about that? Do we have a definitive answer? 4? I'd probably agree with you on 4. Okay? It does look like there's some joint involvement, which I don't know how well you guys can see it. Okay. Just 1 second, sorry. And then,
Could you explain where exactly, why you said it was a 4?
because this is coming up right through here. Now again, these x-rays are pretty poor, but to me, this looks like, to me, it's getting up and into the joint right through here. And I'm not sure how well you guys can see that.
Okay.
But again, you may be kind of splitting hairs there a little bit. Here, the next one is definitely one that does involve the joint, so that's pretty easy to tell. Okay? But to me, this is a 1, 2, or 3, or 4. I'd say 3. Okay? But again, the key factor is it does involve the joint. So when you call us, just let us know that. Okay? Other fractures. Something else I want to hit on. Ankles. Okay? Here, again, joint involvement, distal fracture. Looks like you have a 4 here, then again you have a 3 here. So to me, this is just really just an unstable joint more than anything. Probably will need some type of fixation with the screw across the medial malleus across here to keep this joint from widening. You also probably maybe going to need a mortise screw, and probably will not need to plate this. It's well aligned though. Okay. Positive arrow sign there. Thanks, radiologist. So, there, and there's how they fixed it. So, pretty simple, easy fracture to fix. Okay. Another thing I want you guys to see. You guys ever heard of a bipartite patella? No. See a lot in pediatric patients. It is a growth plate. They're graded 1, 2s, and 3s also. But I can't tell you how many times this has been sent to me. Oh, I have a patella fracture. Okay? Have a 12-year-old kid, fell off the bench, send him over for, to be seen for a patella fracture. So we think, hey, we got to, this could be a pretty bad injury, that type of thing. But this is just basically from the growth plate completely not fusing. So this is a type 3. It's coming right through here. You can see this is bilateral. And so this is pretty normal. This can be quite painful though. And they sometimes can be quite unstable. I think that we've shelved a few of these out where the patient was having pain, but x-ray both knees, and I think if you x-ray both knees, you'll see that it's on both sides. So the other one that's very similar to the patella itself is what's called an ossocromial. So on the shoulder, the growth plate on the distal acromion. A lot of times we get calls from, again, Frederick, or not always picking on Frederick, Goody or wherever, saying, hey, I have a scapular fracture. And You know, those kids drive 3.5 hours, 4 hours, and they get into our clinic, and you're like, this is normal, okay? So kids are tough. Kids are tough to read fractures on. Can you do a lot of harm by, putting the kid in mobilization for a week or two until they get to us? No, not really. Again, kids are salamanders, they heal very, very quickly. The way you can hurt a kid, though, is just going back to the Saltairus 2, 4, just not recognizing that the growth plate's involved, and then you not getting them to us quick enough where we can take them to surgery. Okay? Questions about that? Okay. There's one I really want you to see on here. It doesn't have it. Anyway, there's a great one, the progression of a mid-shaft humerus fracture on an 8-year-old patient, and basically just followed him from fracture time, how much displacement there was. I think there was about 60 degrees of angulation to it. But it showed it over the course of time up to 6 months, and just how well the kid was able to remodel his bone. Mid-shaft humerus fractures, how we worry about those on kids, really just is there any nerve involvement? But if you just put them into a hanging cast, kids will realign themselves. They'll put down a bunch of callus, and then 6 months after the fracture, you won't be able to tell there was ever really a fracture. Okay. We had a kid who was 14 here not too long ago. He had a mid-shaft humerus fracture from throwing a baseball. So what's the number one thing you think in your head? Tumor. As soon as we heard that, oh, there's absolutely, this kid's going to have a tumor. Luckily, no tumor. I had bone biopsy, CT scans, and MRIs, didn't show any tumor. It still makes me worried that, from a 14-year-old kid just throwing a baseball, for him to get that type of stress reaction. Going back to look at his history, and this goes back to what Dr. Woodson was talking about, is having kids play one sport. He played baseball year-round. Do not let kids play baseball year-round. If you have kids that play baseball year-round, that's great. Stop. Okay? Seriously. I was a college baseball player, and knowing what I know now, if I would have known back then, there's no way I would have done what I've done to my body. So, because it really does affect a lot of the kids. Okay? And I see it way too many times. If you look at, kids and that play baseball year-round, and if you look at the Cy Young Award winners from the last 20 years, I think the last study was out, they're all from the North. And why are they from the North? Well, because they can only play baseball 6 months out of the year. It happens way too much here in Oklahoma. Okay? All right. Any other Pete's questions? Questions in general? No, you guys just want to break for your next lecture, don't you? Yeah. Okay. So you guys will go to clinicals when?
January.
Okay. Oh, wow. Schedule's already lined up? Everybody already has?
Absolutely.
So you guys have,
No. But it will be Wednesday.
Oh, really? Okay.
Yeah.
Like tomorrow?
Like tomorrow, yeah. That's what I'm doing tomorrow. So
Yep.
everybody will have their January tomorrow. But don't contact them until I tell you. Dear gosh.
They're just cookies, I didn't.
Well, I hope you guys will come rotate with us. Of course, we're McBride. I don't think I mentioned that earlier. Been in orthopedics for 10 years. Worked for another orthopedic clinic before. Had students every month from OU, and then once McNeil left, I kind of quit taking their students. So, no offense to them. It's just,
Let me give you some paperwork before you leave. Right?
I'll run to see Amber. But no, I hope you guys will come rotate with us. I think you'd have a lot of fun. We have fun. It's really relaxed. Dr. Woodson, he's a great surgeon. He does a really, really good job, and we keep it fun. And you see a lot of people, you see a lot of good things, see a lot of trauma, too. And what I would suggest, for clinicals, go do the hard stuff. Go do the stuff that you think, there's no way I can do that, I don't feel confident in that, because That's the big thing, is this is really the opportunity to get a chance to do that. Last time I got to play the chest tube band, it was 10 years ago. Okay? Which, I don't want to do that anymore. Okay? Yeah, I'm good. When you go to surgery, ask the anesthesiologist and nurse anesthetist, hey, can I innovate? Can I, because that's the best time to train is on those patients. Do as much as you can. Don't be the one that kind of stands in the back and say, I'm just going to kind of skate through. Those PAs typically don't do very well. And I think we're getting a lot of that from somewhere else right now.